Welcome to episode 11 of Value Health Voices, where we're going to be speaking with expert and innovator Dr. Vipan Nikore about reimagining home-based care and the value proposition. So let's get into it. Dr. Nikore and I know each other for over 20 years now when we attended a business school together at Yale. In fact, we have 3 MD MBAs on this call at the same time. So it's a first for Value Health Voices.
But that, this is great to be here. And don't call me Dr. Nikore. That's
All right, I'll call you Vip.
Business school, do not call me.
All right, I'll call you Vip. So Vip is the Chief Medical Director of TD Bank globally and the CEO and co-founder of Home Care Hub and a practicing internist at Trillium Health Partners and Cleveland Clinic in Ohio and Toronto. He is an investigator at the Institute for Better Health and previously was course director for MIT's Global Health Informatics course. He has worked clinically in Haiti, Peru, Ghana, Nepal, and India. And he is a former IBM software developer, led projects at the WHO in Switzerland, UNICEF, Sun Microsystems, Citibank. He completed his internal medicine residency at Cleveland Clinic, his MBA from Yale, and he was the former winner of Canada's Top 40 Under 40 Award, which now is quite a few years ago, I imagine. But yes, welcome Vip to the podcast.
Thanks, Summer. Thanks, Anthony. Great to be here.
Thanks for joining us.
So Vip, maybe you could just tell us a little bit more about yourself and what got you inspired to be an entrepreneur.
Yeah. So, I mean, you may remember some of this, but, my life before business school, and I did business school before med school, was a little bit non-traditional. I was a software developer. I was out as a student during the dot-com boom out in Silicon Valley, right? So, for me, it was such a formative time, right? Programming away when there was so much innovation happening with the internet. I remember in undergrad, we built this team and students, we built this, MP3 player that locked down. It was on like the front page of our student newspaper, and people are asking me like, are you guys going to commercialize this? And I'm talking to people and my cousins are like, well, you're going to have to go against Apple. Are you ready to do that? And I'm like 20 years old, right? But it was so exciting to me at the time. This is way before Spotify, we're the Napster days. So for me, it was just such an exciting time to think about, could we create the next Microsoft or whatever it might be, and thinking about how technology can have such a great impact in a positive manner on people. That for me, I've known I've wanted to be an entrepreneur since those undergrad days. And I knew I was going to go to business school during those days. What I didn't know at the time was my path towards med school, which as time went on, I really gravitated towards and am very happy about that. But I've known early on, and then of course during business school, a lot of the lessons and teachings, I was thinking about entrepreneurship then. So I knew the day I stepped into med school, I wanted to start something up. And then during med school, I started a nonprofit called UFlow, and we empower underserved youth to start their own service projects. And we expanded that to 5 cities. And it was a really meaningful project for me from an impact standpoint and from a youth mentorship standpoint. But it also kind of got me away from the med school books and a lot of the rote memorization and just the science-based stuff, back to like thinking about our Yale days where like, how can we build something to change the world? And that was very exciting for me, and I built new skills and whatnot. So I've kind of been waiting. I'd been waiting a long time for this moment, let's just say.
Yeah, and it's funny you bring up those days because you're right. I remember talking to you back then being like, are you crazy? Why would you go back to med school? You were down this path, but I guess you used all that knowledge and skills you learned at your time, not only in med school, but also residency and practicing to kind of create new ideas to be an entrepreneur.
That was the plan. Yeah. Here I am.
Go ahead, Anthony.
You brought me back. I remember. So unlike you, I did the MD and the MBA as an integrated program. And I remember very acutely that tension between the two kinds of thinking, right? And also the two crowds, the med school crowd I was with, the MBA crowd I was with. You brought me back as if it were yesterday with your comment.
Totally. And we all recognize that difference. And Amr was one of those, MD, MBA integrated people. And I was like one of the MBA people about to sort of, or wanting to join on the inside back then. And it's, very two different ways of thinking, no doubt.
So that pivot then, after you decided that you wanted to get back into this, why'd you focus on home healthcare? And also there was this bit where you went to, and you became the chief medical officer at TD Bank, and you continue to do that. So how did all that kind of play out for you?
Yeah. So when I finished residency, I went out to MIT and I was teaching out there a bit. And then I was at Lux Capital as well, doing some venture work with them out in New York, and doing some clinical work in Brooklyn, and also at Cleveland Clinic, our main campus, and some other locums, et cetera. So it was really almost like this made up program, because I knew I wanted to go back to Canada. Ultimately, I'd been in the US 12 years, kind of wanted to get back to Toronto soil. And I went back and I was doing 42 weeks clinically at first, really getting my clinical chops in. And I'm a hospitalist, so I'm discharging lots of patients, and I'll get into how that led to sort of the home care hub piece. But pretty soon after, actually, I had an opportunity to become director of medicine in my department. So I took on some hospital admin work for a while at Curtin Valley Hospital at our Trillium Health team. I was still working at Cleveland Clinic, and then we were seeding the idea of home care hub at the time. Our CEO of Cleveland Clinic Canada, Mike Kessel, asked me if I wanted to be the guy we bid on for TD Bank's chief medical director role. And at first I was like, well, I'm kind of starting to move towards this startup thing, and I'm already busy. And then after some conversations, we went for it, we got it. So my role at TD Bank is through Cleveland Clinic. It's a program we've developed where we service over 15 different large organizations as their chief medical director, a lot of the big companies out in Canada, and now some in the US as well. So I've been able to sort of straddle a few different hats. At TD, I oversee their 100,000 employees. It's really, actually, what's really interesting, Amr, back during business school, I went to some of these net impact conferences, and I remember meeting a chief medical director of, I think it was Coca-Cola, maybe of Africa, I think. And it was a really interesting role. So I'd always had that in the back of my mind. So when this came up, it was pretty cool to be able to pursue that. So I've been in that advisory role 8 years, was really, really, I would say, unique during COVID, as you can imagine, and has stabilized since then. So that's kind of my journey. And then ultimately, I left my role at my operating role as director of medicine, and I went pretty much all in on home care hub from an operational standpoint there.
Vip, maybe you could set me straight on this, because I might have this wrong. I have some ideas in my head about interacting with people in similar roles in Europe. But in Canada, are you functioning, and is your relationship between your role at Cleveland Clinic and TD Bank and perhaps other firms in Canada too, is it serving as a kind of a supplementary program on top of the access that people have to healthcare, through their, provincial health service? What exactly are you doing there above and beyond the care that, everyone has universally in Ontario?
Yeah, it's
or elsewhere in Canada?
Yeah, it's a bit of a mix and unique to each client, because Cleveland Clinic has so many different services, from actually providing care to providing strategic and advisory insights, et cetera. But for my role at Cleveland Clinic, or at Cleveland Clinic at TD, it's largely on the medical advisory work. So the 100,000 employees we have, more on strategic healthcare advisory, as opposed to providing medical care for the patients themselves.
Got it.
Now, we have 30,000+ people in the United States. So from a policy perspective and advisory perspective, it's quite different, my role on Canada versus US. It's all integrated, but there's more we can do as an employer-based health plan in the US compared to Canada, where the government's already paying for that. So it's a different type of insight there.
Yeah. And I can only imagine during the pandemic, they would all probably turn to you to find out about masking policies, vaccinations, lockdowns, return to work, all that, right? You're the only one who knew all the answers.
I was trying to figure out the answers. It was quite the time. It was, and I had just launched Home Care Hub February 2020, and I'm an internist, so I treat COVID patients. So I was trying to cut down on my clinical work, but obviously I couldn't do that when we didn't have enough docs. So I was actually doing more. So between it all, it was a pretty crazy time. And then just to flesh out your role with your question, actually, Anthony, on supplemental, Cleveland Clinic, we do this for Air Canada. They have already had a long-time chief medical director. So we provide an infectious disease doctor who serves as a supplemental chief medical advisory team to them. So I gave a talk to Air Canada not too long ago as part of our Cleveland Clinic team. So the relationships vary in many ways and customize it towards different clients.
And my question was motivated by, like, for example, in the UK, are a lot of, let's call them executives, even not necessarily at that level, but director level and similar, who are provided with a private insurance coverage on top of their public, access they have with the NHS. And then there's some relationship with perhaps someone in a role like you overseeing that product and how those folks access care through that
Yes.
private care on top of their public access.
There is. And we have TD in the UK and Cleveland Clinic in the UK. So I've actually been involved in some of those conversations actually overseas as well.
Great. Well, maybe let's talk a little bit about your startup then, a home care hub. Tell us about it.
Yeah. So you were asking how I sort of got into it. And early on, when I was again, full-time hospitalist, I have a couple old friends of mine who were really sharp lawyers, and they were in the home health space. And they called me up, and we started talking about innovative disruptions in the home health industry. I quickly brought on my co-founder Rahim Lalani, and again my other two co-founders Brian Kwan, Jay Vagela on the legal side, and we had a pretty good breadth of discussions on what we could do. Spent a lot of time brainstorming, figuring out the best path forward to improve the system. But for me personally, the drive was, as a hospitalist, I came back from the US to Canada, working in both systems. And we had about 10-15% of people just sitting in hospital beds with nowhere to go. And I thought, in what world does this make sense that people are waiting in the highest cost place to go to a place, generally a nursing home, that they don't really want to go to, which actually costs the payer, in our case in Ontario, the government, quite a bit of money. Like, what world does this make sense, right? And then I started peeling back more and more layers and recognized that the problem is really universal across North America, but even globally as well. And obviously we know the aging population. And I think I didn't notice it as much in the US because we have so many SNFs that we can discharge patients to in the hospitals. And we're kind of just kicking the problem down the road, right? Like there are people stuck in hospitals in the US, no doubt, even back then. And it's only worsening now. A lot of SNFs aren't even accepting patients. But half the problem is also in the SNFs and getting people out to a community-based centers. My first internal med rotation in Chicago, I was at the VA. I remember my first patient, he was like, I'd rather die than go to a nursing home. And, that was my first patient. I'm in nursing home. I'm a medical student. So I'm spending like half an hour just trying to convince them. Some of those memories really stick with you, and you realize there's got to be a better experience for older adults to have in their life. And again, I think nursing homes have to get better, and I hope they get better. But ultimately, what are some alternative paths that we can create? And that's sort of the beginning of
Gotcha. And for our listeners, SNFs, skilled nursing facilities. But, so just from 10,000 feet, like for a layperson, I'm kind of like, okay, so you're talking about, nursing homes, like just doing the same kind of stuff at home. But am I missing something, or is it just that? Or is it something else?
It is something else. And I realize I haven't even got into what we do. All I did is sort of tell you the why in terms of why I got into this. But ultimately, what we do at Home Care Hub is assemble networks of small care homes on demand as alternatives to nursing homes. So instead of having 150 people go into one 150 person big nursing home, that's one extreme. The other extreme is you have everyone in their own home, 150 homes. And we know 100% of, it's like literally polls show 90 or 100% of people want to stay in their own home. Like, we know that. But the reality is that's obviously not happening because people are going to nursing homes, and there's thousands, millions of people across the world going into nursing homes. So obviously there needs to be a place outside of their own home. And our hypothesis is, instead of those 150 people in a nursing home, you can create this distributed network of smaller homes, 35-person homes, 15, 10-person homes, and create them quickly, more efficiently, with better outcomes on demand. We basically run a platform that helps create these homes, and we run them in tandem with other partners. We run some ourselves as well. And we've built that entire technology platform to create that. And we partner with payers and health systems to help expedite hospitals, for instance, to discharges, et cetera, as well.
So what are some of the ways, the metrics that you demonstrate that this is a better solution? Could you get into that a little bit? Maybe two or three of the
Absolutely. And metrics is key. And we launched up in the Toronto area initially, then in 2000, yeah, last year, 2024. I get my years mixed up. 2024, we launched in the U.S. in Wisconsin, and by August, about 7 months after launch, we had already started to show decreased length of stay, decreased readmissions, as an example, when we're involved compared to when they're going to a non-home care hub home. So I presented that to the Wisconsin Hospital Association in tandem with our health system partner, the Freighter Health System, which is Medical College of Wisconsin, last year. So that's a couple of key metrics, of course.
Yes. And I'd be interested to know if not only Freighter, but perhaps other interested clients that you talk about what you could do for them in the context of their value-based care contracts. Because if you are materially reducing readmissions, then that's typically one of the metrics in those kinds of contracts that are the most weighted in terms of, the bonuses that the provider side can get by preventing those readmissions within a certain period.
Yeah, absolutely. And that's exactly where we're going. Measurement is key. Being able to take care of really hard patients. And that's really what our focus is. A lot of times people will almost lie to us when they refer to a patient to us, which is not good. They'll say, or they'll leave out information. And this happens a lot in the post-acute world because it's hard to get people out. So sometimes there's not always transparent information, nursing assessments, et cetera. We encourage people, just tell us. We're not going to reject this referral just because they're hard, because we're designing a system to take really hard patients. We have some of our partner operators on our platform who take the hardest people coming out of jails and they've had no readmissions, et cetera, in 2 years. We want to take that, but we have to know so we can make sure the supports are in place so that we can put them in the right environment where they will thrive. But we have to have all that information. And when that happens, we're measuring all this out over the next couple of years, and we'll have more and more data to show. And to your point, there's a significant savings for all these health systems and payers if we continue to provide better care and better outcomes. But what we've done is we've created the system so efficiently that even if our outcomes were the same, we're still going to save them actually a tremendous amount of money because of the way that we've set up our system in terms of our operational efficiencies.
From the length of stay standpoint.
Yeah, well, not even that, just from the cost, our cost tends to be about 30% lower than a traditional nursing home, as an example.
Got it.
Or traditional assisted livings that are out there. We're taking
And that's
care
just because you don't have to deal with as much overhead and you're using like economies of scale or something, or
it's almost like if you ask Amazon how they're so efficient, right? Like they're looking at every little piece of the supply chain. Even one of our partner developers who build houses at a very low cost, I was asking them, how do you do it cheaper? And they're like, it's every little detail in the whole stack, in the whole systems, being able to aggregate economies of scale, to your point earlier, Amar, to technology that we have built. All these little things add up more and more. We're not building any infrastructure either, which also makes it low cost.
I'm curious. So, you're talking about all these efficiencies that your company creates, which obviously help reduce costs. But in terms of what is the care gap that you're filling that allows for the readmission rates to be lower? Are you helping with issues related to like social isolation for some of these patients? Or what is some of the care gap you're filling?
Yeah, a lot of it, these smaller mom and pop nursing, I wouldn't call them nursing homes, sorry, mom and pop providers of these small homes that run these homes that are on our platform. They don't necessarily have access to, all their own activities coordinator, to really good nurses that we have on our team who can do the assessments and provide oversight, medical care as well. So there are all these layers that we can bring in to say, otherwise this person would not have been able to stay in the community. But in partnership with Home Care Hub, they were able to now stay in the community.
I got to ask you a question about patient risk stratification. And I'd like to ask you it in two ways, if possible. For your own purposes, for figuring out, let's say, how complex a patient is, for the right fit, the right placement for that patient, do you all have an extensive, let's say, set of variables, set of characteristics of that patient that you look at to say, okay, this is a high-risk patient, this is a rising risk patient, or this is a low
we have a variety of different, I guess, intakes that they have to go through. And it often depends on the state because there's certain regulations, like in some states are the operators of our home have to do their own intake, et cetera. But we'll often do a supplemental one instead, and we get extra information in that. And then sometimes if it's a behavioral patient, we do an extra layer of a review as well. And we're integrating our health record into hospital health records, et cetera, as well. So we can get more seamless information. And the deeper the partnership we have with the hospital, the more we can even get some of this other information that's sometimes not captured in the notes as well. So we have,
You read my mind. That was
and
my
we have
second
our
part of the
nurse
question.
talking to their nurse, it's getting all that information, and we're figuring out information. We're talking to families, and we get all that to be able to risk stratify properly. And it's hard. And we're over 5 years old now, but we've, got it wrong at times too, where we missed information, right? And we're like, maybe we should have asked this or done X, Y, and Z. And it's not easy getting, maybe someone who, as an example, has a significant mental health challenge out of a house when that's not the right environment and they're living with others, right? Like, sometimes, and then how do you get them, assessed properly once they're in the home? So it's really important to try to get it right before they go in the home, because it's not easy often once they're in the home.
Absolutely.
So you were talking a little bit about some of the regulatory environment. Maybe you could comment a little more about that. Like, what are some of the barriers you're facing in terms of regulatory licensing, all that?
Yeah, it's a common question I get as the CEO of a company trying to create a scalable company in a environment where every province and every state is so different, right? And for example, every small home, most states have some structure for some of these smaller homes or different ways of creating them, but they vary significantly. So in Wisconsin, they're called adult family homes. If it's 3 or 4 people, 5 and above is a community-based residential facility. They have different regulations for each, but generally Medicaid does pay. We have a payer, so Medicaid will pay in reasonable rates for these. A place like Pennsylvania, they have personal care homes, but Medicaid doesn't pay for the personal care homes, right? So, the strategy is quite different. It's hard to create a scalable strategy when it's so wildly different. Whether they're paid, how much they're paid, what they're called. Like it's quite very complicated, let's just say. But ultimately, we know there's only so many different sort of templates. And Matt Atkin, he's one of the guys who helped scale Uber. He was employee 100. He's on our he's a board observer and on our home care hub team. So speak to him quite a bit. And they had so many different ways of thinking about it at Uber, and they really distill it down to really different playbooks. And we do believe that even amongst the complexity in every state and province, there's only so many different ways you can do it. And that's why we believe we're getting strong, we're getting good in certain urban areas, rural areas, certain areas where Medicaid doesn't pay, or they pay average rates, or they pay high rates. So I think that's the biggest policy challenge. When, at a even bigger picture view, Medicare, like, they largely don't really pay for housing, which is a challenge. And that's a whole different discussion around that. So if we could get them to pay, that would be amazing.
I'm struck by what a virtually perfect analogy or a tie-in between what you're doing and the variability in regulation that you face and what Uber faces, right? Because like is Uber in certain countries, they can just do Uber Eats. And then another geography, they can do Uber X all the way through Uber Black. And it's really a beautifully aligned comparison.
It really is. And we're lucky to just have that insight from, Matt on our team and be able to ask him all the time.
Amazing.
But it's a challenge, and definitely learned a lot over the years in terms of, which, from a strategy standpoint, which of those templates do we want to go after in the first, certain number of years? Which ones do we want to start conversations? Because we know that's more of maybe a policy change that we have to work on, and that becomes more of an advocacy exercise. Doesn't mean we don't want to start those conversations, but there's only also so many hours in the day and so many people. You can't be in every state and province at once, so you got to pick certain ones that make most sense.
And along these lines of advocacy, then, is there a dream scenario where what would you wish CMS or the states or payers could do to help, allow for innovation like this?
Yeah, there needs to be more of a focus and funding on alternative models of care outside of nursing homes. The Greenhouse Project is a nonprofit out of DC that we work quite closely with, and they've been proving out these smaller home models for over 20 years and really advocating for alternative models. There's this newer Einstein option and others who are really fighting for the same thing, to say, let's get dollars towards smaller care homes, whether it's through Medicare or whomever. There has to be options that provide that, because in smaller homes, you can have more personalized care when it's done right. It's even been proven about some of the better outcomes and cost savings on the system when it's done
I think about locally here, not to get too much into the geography where I am in Southwest Ohio, but we really have a bottleneck in terms of LTACs, in terms of SNFs. LTACs means long-term acute care facility for the sorry about the abbreviations there, but for the listeners. But I really think that it's a tremendous solution, and I don't know what the situation is. Now I'm going to inform myself after what it's like in terms of funding here in the state of Ohio for these smaller home solutions like you guys are doing.
Yeah, it's interesting you mentioned that because, as a hospitalist, you're kind of taught that, okay, when someone gets discharged from the hospital, here's what their options are. And obviously, our great discharge planners and social workers really dive into the weeds with our patients. But we're taught as the physician that's really, you go home with home care. You go to a SNF, skilled nursing facility. If they're more complex, like on the US side, LTAC, right? Or there's, typically expensive assisted living option. That's kind of it. No one ever mentioned anything about like these small homes, both in the US or Canada. And my goal is to really, Home Care Hub's goal is to create this really standardized common path to say there is a world you can go to a smaller home and seamless, and it's going to be a great experience. And for us, it's all about choice. People can go to wherever we want. I want to see nursing homes do better. I want to see more home health. It needs to be an all out approach when we look at the number of beds that we need in the decades ahead. Like, it's just math. Like, it's not even close. Like we have to do something. So, my goal is to create sort of this main path. And even, things like adult day programs. I didn't even know what that was till actually I got back to Canada, and day programs are amazing. Drop off your loved one at 9 a.m, be able to pick them up at 5, and they get programming and socialization. And these alternative paths need to become more mainstream.
That's true. So in the U.S., as I understand it, we don't have, at least on any large scale, programs like that, and we see more and more the epidemic of loneliness of areas, again, to name the state that I live in, an aging population here, not a whole lot of young people moving in, and so that problem becomes more acute with the passage of time.
Yeah,
Yeah,
remember the
absolutely.
former Surgeon General said it was a pandemic of epidemic, I guess,
Epidemic of loneliness. Yeah,
of loneliness. Yeah.
that's a great
Around
point.
loneliness. Yeah. And who's one of our alumni
Yes.
from our program.
Yes, indeed.
He's talked a lot about social isolation. We know, it's equivalent to, smoking a pack of cigarettes a day in terms of the harmful effects. But, there actually are some day programs in the US as well. They're, again, just not as mainstream as they all should be. PACE programs, if you're familiar with them, they integrate a lot of day programs. I mean, the core of what they do is often around a day program. These are basically alternative models to nursing homes. That's, again, another wonderful program that's starting to get more and more traction. But these are the models that need to become accelerated as fast as possible.
Sure.
Are you using any AI or any other technology to right now in your models to help create some of these efficiencies?
Yes. I mean, as you can imagine, with my background being software, we
Exactly.
have a team of pretty awesome developers, and we've been building software for years on this, and really the stack of software for small care homes for them to run their operation, to software that if you took 100,000 people, it would tell you where to put a home, who should live together, etc.
Wow.
So we've built a lot on the tech side, and we have a lot of technology that we're not even using yet because we're not at that scale yet, but we're building. So it's pretty exciting to watch it happen. And then we're also part of the AARP Age Tech Collaborative. So the AARP Age Tech Collaborative is a really great incubator program, and then they ended up investing in us as well. And so um, we get to almost have first access to all these other age tech collaborative technologies because they want to be the leader in age tech out there. For those who don't know, the ARP is the main retirement organization of the United States. And so we're layering in lots of technology created by others into our homes as well, which is the other area where this comes in.
It sounds like you're really onto something, really filling a massive need both north of the border and here in the U.S. I'm curious, Vip. Amr I think sort of asked this question in a little bit of a different way earlier, if I understood it, but just to circle back to it, from a standpoint of policy, if we can, I think certainly we have listeners outside the US, but maybe we could focus this next part of this conversation more in the US. From a standpoint of policy, are things that we should be advocating for, lobbying for, that would be helpful to the success and the scalability of solutions like you're offering? And what could we do? What should we be talking about when we interact with the government, both Amr and myself, that would be supportive of your approach?
Great question. To sort of distill it down, and I always say I'm not like, the policy expert. There's people who've been doing this for 30 years, every day, day in and day out. So I'm an amateur compared to some of these other people. My belief is, generally more funding you can put towards housing, that's always going to be helpful, right? Because healthcare and housing are linked, I think, much more than we often give credit for. So the more you can fund housing, you're going to get better outcomes for patients. So whether that's through Medicare housing, et cetera, being able to fund alternative models to traditional nursing homes, that's going to be really important as well. And then even just, and when I say that, that's PACE programs, that's small home models, as I sort of mentioned before. So just as, again, a small example, Medicaid not paying for the Pennsylvania personal care homes. Again, there's different paths, but I think that's, that would be number two. In general, putting a more seamless process to creating some of these smaller homes. There's some homes we've created where, or we're working with some states, and they make it nice and simple. You create this home and you follow these directions, and it makes it nice and prescriptive. And then there's some, it's like, it's so hard to find the information. They have to, I'm getting fingerprinted. Like, there's doing a million different things that, I've got to fly down to the state. Our team has to do this. We've got to do 100 different things. Just, and imagine, we don't mind doing it. We're, kind of a growing company. But what if you're a smaller mom and pop and and you're thinking about different ways to get involved and help people, and you have to jump through a million different hoops to do this? They're just going to say, well, I don't want to do this. And how are you going to see that infrastructure? So there's sort of the three big ways I would say, yeah, you could help. But from a housing perspective, I think is the big picture.
Yeah.
Sure.
One of the things you mentioned, I thought that was interesting, and it's got me thinking. So you were using technology and these learning models to potentially figure out where opportunities for your company and to improve access for some of these seniors there. But then the other thing with the data that's very interesting is you're collecting data from people at home getting this care, which is very unique. Not many people out there have that kind of data. And I feel like that data would be very valuable to payers and health systems. Can you talk a little bit about like what you're thinking in terms of that?
Yeah, I mean, for me, I'm a clinician that wants to drive outcomes, so I see data as an opportunity to drive better outcomes. Also, as I mentioned, a clinician, so my goal is to protect people's data, right? So from a HIPAA, PHIPAA perspective, people should be able to know that they're in there and that their data is safe, and we're a reputable company that's going to be just using whatever information we have as a way to serve them better, and that's it. That's the way I look at it.
Very noble approach.
And then I guess, to the future, what do you think the space is going to look like in 10 years, home healthcare in general, and how you and your company would fit in?
We're really going to ask him 10 years out? I mean, maybe it should be five.
Maybe five.
Even
Let's
five.
go, let's go
long.
five.
5,
Let's
10
go 5.
years. I can do
Yeah.
10. Either way, I think the future is going to be this distributed network of smaller care homes called Home Care Hub. Of course, I got to say that. That's the goal, and that's what we want to create. It's the idea that, things get really challenging, maybe with your parent or someone's, a spouse passes away and they're otherwise about to go to a nursing home 20 minutes away, but now they maybe can walk. And we've seen this happen with some of our own stories where now they're literally 5 minutes from their son or daughter, as an example, 5-minute walk, because we popped up there's a home care hub home in that area. So, having these in every little community, we think that is going to play a key role. But I think there's going to be day programs where that pop up more and more. There's going to be better nursing homes. They have to have better nursing homes. And nursing home reform there, even at the large scale. I think caregivers themselves are going to be more empowered also There'll be more living caregivers, I think, from overseas, et cetera. There's already some of that. But I think there's got to be all these different layers that you have to hit to solve this crisis. So I think we're going to hit them all.
That's a beautiful vision for the future. And really what you're talking about is from both the commercial side, but also from the governmental side, a kind of a demand for and a delivery of dignity for people. And that's a powerful thing. And, different countries take different approaches to try to deliver that. And different countries have different, let's say, valuation or a different prioritization of how important delivering dignity is to older people. And the more we can talk about it and come back to it here in the US and keep it front of mind is, I think, important, because with all the myriad focus that government has, it can get lost in the shuffle.
Yeah, it's a great point. Dignity is something we've lacked for a population that deserves probably the most respect in society. And it's unfortunately not always been the way. It's hard. You need a lot of patience. It's not an easy thing to do, but we have to invest the time to make that happen. And then just from an economic standpoint, I mean, I'm an internist. We care for most of the admissions. Most of the patients are 80 and up. People who we like to glamorize often a lot of wearables for young people. Yeah, that's great. All really important. The people who get sick and drive up costs in healthcare are generally people, older adults in society as well. So it not only is the right thing to do, it makes the most economic sense. And I do think we have to generally as a society accelerate on this faster. Everyone, from health systems to payers to governments, everyone's got to move quicker to solve this problem, because we're going to be in big trouble if we don't. And that vision of mine 10 years from now is not going to be reality if people don't move quicker. So it's coming.
Yeah. I also wanted to ask you, so one of my favorite podcasts is How I Built This, right? And I think, I'm curious, like what keeps you up at night in terms of just as an entrepreneur, having to deal with funding this operation of yours and constantly looking for new rounds of funding and financing and how do you handle that?
Yeah. Well, before I get into that, a great podcast, How I Built This. And, I was on stage at CES, the AARP had sort of on their Age Tech Collaborative stage, and Guy Raz from
Wow.
How I Built This was right on before me. He was like 2 talks right before me on stage.
Well, maybe this will be your entry level podcast. And then once, in the 10-year plan, then you'll be talking about your success and how I built this.
No, I'm going to talk about it on this. This is the place to be. Value Health Voices.
Too kind.
But keeping me up at night, I mean, one thing I can tell you, entrepreneurship is really hard. I talked about how I've always wanted to do this. And, I have a cousin of mine who had gone to, Harvard Business School, much older than I am. And he started multiple companies. I remember when I was getting this going, he's like, "Are you sure you want to do this? You'd be a great VC. Why don't you do that? It's such a grind." And I'm like, "No, I like not a shadow of the doubt that I'm going to do this." But I get it. It is all consuming, very hard, everything from raising capital to the things that come up every day. If you're creating a truly disruptive, innovative model, you're going to encounter things that no one else has come up with. And there's something even happened today with my team. And I remember just thinking, like, I told our team, I was like, you can't even write this stuff up sometimes. The situation, the scenarios that come up, especially you're dealing with really hard patients and people live together and working with the hospital environments and healthcare. It's really hard. So keeping me up at night is everything. But
Yeah.
obviously the big thing is, obviously fundraising, acquiring customers. When you start becoming a venture-backed company, you have metrics, targets you've got to hit, and you need to show scale and you need to show growth. And we're lucky all our investors are really exceptional, pushing us at the right point, but not toxic in any way. So getting the right people who understand healthcare and the long sales cycles, et cetera, that happen. But yeah, that hitting those growth targets and all of that world that we're in is stressful, and making sure we're taking care of the patients. I love seeing the outcomes, the day-to-day stories that we see. We have someone with ALS we got out of the hospital who had been there for a very long time, and we were able to get them out in a relatively short order, and their family, everyone's so happy. And I stopped by the home the other day. Those are great stories, but I also, we're going to see more and more metrics, and I want to see these metrics blow previous metrics out of the water, the status quo. So that keeps you up at night. I want to hit that. We're not creating this for average. We're creating this. We want Cleveland Clinic level of care in the post-acute world. So yeah, lots of things.
It's outstanding. With all those, let's say, cautions given for those who've listening to you and made it to this point in the podcast and are saying, Vip's story is a story I want to make my own. I want to be a physician entrepreneur, or let's say even maybe not a physician, but they're in healthcare and they want to build their own thing. Where would you direct them? Where is there any tip you would give them, to any particular resource or other place to go to, I don't know, start to test their mettle in terms of doing this?
That's a great question. And I guess it kind of depends on what path you want to go, whether it's entrepreneurship or you want to go down, a consulting route or venture capital route or policy, governmental route. So, but I think you do need to talk to a lot of people and immerse yourself in that world and just get realistic understanding of what it's like to be in that world. And then even if you do some things for free, I've had to do those things in my life a lot just to learn. You just got to do that sometimes for that learning as well. So I know it's sort of a generic, broad answer. I don't know. What do you guys think? You're all in this world of
No, Vip, you're one of those people
alternatives.
who I think is the epitome of you say yes to, and any opportunity that comes your way, because you never know where it will take you. And I mean, and look where it's taken you. It's you've done so many things across so many spheres because of it. And so I think that is kind of some of the advice you're saying.
You know, a lot of shots on goal you've had, Vip, I guess, in your
Yeah.
in your story. And but for me, I would just say that I've often thought about it is looking at, finding somebody who is a success in a given pathway, a given role, and saying, well, okay, this person has achieved success. Would it be success for me? Would I want my life to look like that in 10 years, or when I'm 45? And now I'm almost 45, but speaking about what I was, like at, I don't know, 25 or 30, I've always found that was the helpful test, right? Do I want my life to look like that?
Yeah, no, that's a great point. But yeah, even seeking out people opportunities when you can. I remember in med school, one of my mentors, David Mayer, Dr. Mayer, I was assigned a mentor, and then I learned about Dr. Mayer, and I'm like, can I switch? And no offense to my old mentor, but this guy he had started a company, he'd worked in venture capital, he was teaching patient safety, he was teaching all the leadership courses, just a super guy, still doing clinical work. And I was like, wow, I feel like based on my background, he would be a good fit. So I just kind of made some calls or talked to some people, and he ended up letting me teach the leadership course to the first year med students when I was at University of Illinois for med school. And now I've been teaching 17 years. I teach at University of Toronto, and it's all because that mentor gave me an opportunity and I sort of sought him out. So sometimes that type of just finding the right people who might be able to give you some of that advice or get you involved in certain ways as well.
Well, this has been great, Vip. We thank you so much for coming on the episode. Is there anything else you wanted to say or plug, or anything else in closing?
No, just your podcast I want to plug, because I've been listening since you guys got going, and I was doing it as a friend at first because I'm like, you're doing it, but now it's an awesome podcast, so I plug your podcast because
I swear we did not pay him for this endorsement.
Well, Vip, I'm motivated now. We got to find probably through you, another colleague in Canada with an interesting story to tell about Canadian healthcare and have them on the program, because why not? I mean, it's
that would
compelling.
be great. I know lots of them in Canada.
Well, we'll do that.
Well, thank you, Vip, and thank you to our listeners, and have a good night.
Catch you again. Bye-bye.
Thanks, everybody. Thanks, guys.